Hey everyone, welcome back to the AABIP podcast. This is Martin Salguero from Memorial Sloan Kettering Cancer Center in New York. I'll be your host for this episode. Thank you all for joining us today. We will probe the guidelines for airway stenting for malignant central airway obstruction from the World Association of Bronchology and Interventional Pulmonology. Today, we're very lucky to have the first author of these guidelines join us, Dr. Uddit Chaddha. Dr. Chaddha is an associate professor from the Icahn School of Medicine at Mount Sinai Hospital and an associate program director for their Interventional Pulmonology Fellowship, better known to many of our listeners as the longtime host of this podcast. Welcome back with it now for the first time as a guest. Getting some formalities out of the way, do you have any relevant conflicts of interest to disclose?
All my conflicts are intellectual, Burton. Thank you for having me. It's truly a pleasure.
Okay, as a reminder, the views expressed in these podcasts are those of the speaker and mine and not necessarily endorsed by the AABIP. As IP physicians, we frequently encounter the challenging condition that is malignant central airway obstruction. While it's one of the more common reasons why we perform therapeutic procedures, approaches to its management vary considerably. This variability is particularly evident when it comes to airway stents regarding their deployment timing, choice of stent type, and procedural care. To address this, 6 months ago, the WABIP developed guidelines aimed at establishing recommendations based on expert consensus and available evidence. But before we begin talking about them, I really want to commend the WABIP for its truly global approach to guideline development. By incorporating the perspectives of experts worldwide rather than relying solely on those from a single region or country, they really have created a very robust and representative document of countries spanning from Japan, Spain, Singapore, Australia, the UK, and France. This broad international collaboration is a significant strength of these guidelines. Now, let's go ahead and start talking a little bit about them. The first question that I had for you is I wanted to talk a little bit why you as a group decided to focus on airway stenting alone in the guidelines and not to include all bronchoscopic interventions for malignant central airway obstruction.
So, as a group, we wanted to stick to a focused topic because if we get into a broader topic, it would have required a lot more resources than we had available to us at that moment. So we decided to stick to a two-part series where we have addressed in this guideline paper stenting in malignant central airway obstruction. And then in the very near future, hopefully in print, you see a similar paper on stenting in benign central airway obstruction.
Yeah, that's great. It makes sense. This is a very broad topic, and particularly for you guys, that this is the first time that you're doing guidelines of this. Jumping into creating such a robust document for all the types of interventions that can be done is very difficult. I know that for malignancies, like it's very difficult talking about, for example, how to approach a possible carcinoid in a bronchus intermedius versus, talking about PDT versus talking about airway stents. These are all very different interventions for very different conditions.
So endoluminal disease, as you allude to, is a very, very broad topic. Addressing questions on ablative therapies and different kinds of ablative therapies, comparing them, etc., I think is a guideline in itself. And it was really beyond the scope of the resources or time we had for this kind of document. But as you mentioned, in general, one of the challenges with studying anything about central airway obstruction is that there is a lot of heterogeneity, right? You comparing debulking or stenting a tumor in the BI to a proximal tracheal stent or a complex Y stent is completely different. So one of the reasons why anything reflected in a guideline is really based on low evidence and often no evidence is the challenges for people in the past to have conducted such studies. As you know, there's only one RCT on airway stenting, and that too incomplete. And really, it's the heterogeneity of the disease, the heterogeneity of the patients, often difficulty recruiting patients due to the acuity of presentations, which have really made it challenging for people to conduct robust studies in this field.
Definitely. And at least for interventional pulmonology and the luminal disease, me as an interventional pulm fellow have been noticing is how more frequent multimodality approach is becoming common for many of these conditions, which makes research either retrospective or prospective and more challenging. At least that's a challenge that you don't have as much with airway stents.
Correct. And not to really dwell on this too much, but really endoluminal disease, if someone sees it, you debulk it. You know, how you do it is
Yeah,
dealer's choice. The saying not to debulk endoluminal disease is obviously not a recommendation anyone is going to give. So really
yeah,
the question would be how to do it. And really the short answer is dealer's choice at this point.
definitely. Talking about the first question that you guys addressed, I think that's everyone in the guideline was on board with that one, which is that whenever we have a patient with malignant central area obstruction that meets criteria for stenting, we should do it because it will improve quality of life and performance status. But you allude in the guidelines a little bit to the SPOC trial of Dr. Duto, where he showed the benefit of airway stents for patients with mixed or intrinsic obstruction, in whose significant patency is achieved and showed improved quality of life after the intervention, but only in those that first line treatment. But my question here is, at least do you in your practice, or do you guys as a group really felt that it makes a difference in these patients in who we have regained endoluminal patency to kind of put a stent prophylactically because we believe that disease will progress all over again?
So in general, if you look at a patient-centered outcome based just on symptoms, we know that the sicker the patient or the more symptomatic they are, the more likely you are to show a significant difference or a larger difference. And that's obviously due to the larger delta and improvement that you can show. In someone who has minimum to no symptoms, obviously you cannot make them symptomatically better. So
Mhm,
it would be very questionable to place prophylactic stents during a first therapeutic intervention. In somebody
mhm,
who has rapidly recurring disease or rapidly regrowing endobronchial tumor, or due to some other circumstance, if a prophylactic stent is placed to prevent a future therapeutic debulking for endoluminal disease, so be it. But
mhm,
in most circumstances, stenting a patient who is asymptomatic and if they've had no downstream complications like post-obstructive pneumonias would not be advisable. Now, if an airway is narrow and a patient is asymptomatic, you also have to factor in whether the downstream parenchyma is viable or not. For example, if
mhm,
someone has damaged, or let's say there's radiation, scarring in the lower and middle lobe, and now you have a BI stenosis, what is going
mhm.
to be the benefit of opening up that BI with a stent? Right.
Definitely.
So you have to factor in not only the symptoms of the patients, but also how likely you are to make them better based on the kind of airway you're opening, which means you need to be targeting central airways. There's little physiological salvage in non-pneumonectomy patients, non-transplant patients for salvaging lobar airways. And we've seen this with the Acquire registry. And then you also have to factor in whether the downstream parenchyma is viable or not.
Interesting. That makes absolute sense. Focusing our interventions on lung that we can salvage instead lung that is pretty much gone, and focusing particularly on patients that are symptomatic or that will have a clinical benefit. Now, in the scenario that we have a patient that has extrinsic compression and is minimally symptomatic or mildly symptomatic, and we have readily available radiation oncology services that can irradiate that tumor, what do you think would be best? Send that patient to radiation, radiate a tumor, versus putting a stent on this patient and potentially having stent-related complications from it?
So my answer to this is pretty similar to the previous question. In someone who is asymptomatic, there should be a reason they are asymptomatic, right? In most case
Mhm,
scenarios, if the stenosis is not significant enough to cause flow limitation, which means that the narrowing is not in excess of 50 to 70%,
mhm,
then in that scenario, the patient will not be symptomatic and you are not justified in prophylactically placing an airway stent. In those
mhm.
situations, something else, such as systemic therapy or focused radiation, must be considered. But again, one of the things we acknowledge in the guideline is that every circumstance is unique and nuanced, and clinical decisions are best made by treating physicians at the bedside. But my answer is, in general, for non-critical stenoses that are not more than 50 to 70% narrow. So in that case, I would not put a stent in.
Now, switching gears to start talking a little bit about stents themselves, your final recommendation doesn't specify a benefit or a preference between silicone and metal stents. However, there are clearly scenarios sometimes where stent material is crucial. For instance, where severe extrinsic obstructions might necessitate the radial strength of a silicone stent. Could you discuss other situations where these technical considerations are important in selecting the type of stent material?
So if you look at the data, unfortunately, there are no head-to-head comparisons, but silicone stenting and metal stenting in published literature have roughly the same association with complications such as granulation tissue, mucus plugging, and migration. In practice, this obviously may not be true. We know that certain hydrophobic properties of silicone stent may make them prone to maybe a thicker quality mucus, which we may not see with say an uncovered metal stent or a minimally covered metal stent. On the other hand, for example, a Y stent should not migrate at all, as opposed to a straight stent. High tracheal stents tend to migrate more than, say, a BIN or a left main stent. And then, of course, the more plastic you put in the airway, the longer length of the stent, the more likely they are to have problems such as mucus plugging. And then there's certain individual aspects to it too. You know, if somebody oversizes a stent, then you're going to get more granulation tissue. If somebody undersizes a stent, you're going to get more migration. So it's very hard to compare stents head to head. I'll tell you what my practice is. My practice is that if I can do a rigid bronchoscopy and I can pass the lesion with my rigid scope or come near to passing it, I always prefer silicone stenting. The reason I prefer silicone stenting is that there are unique complications to metal stents, such as tumor ingrowth, fractures, etc., which in my opinion are unfavorable. But the main reason I like silicone stenting, and you have alluded to this in one of your papers, Burton, is that nowadays patients are having a high degree of response to anti-cancer therapies. So what ends up happening is most of the stents I'm putting in are being taken out. So the ease of removability of silicone stenting, in my opinion, far exceeds that of metal stents. Now, when the rigid bronchoscopy is not feasible, when certain stenosis are very tight and fixed and we cannot bypass them with a rigid scope and need maybe a wire to get through or a thin catheter to get through, in those situations, sure, metal stenting can be considered. But again, we're talking about the guidelines. In general, your complications should not dictate which stent should be put in. It's other factors such as ease of removability and technical aspects that need to be factored in.
Yeah, and definitely makes sense, kind of like individualizing the care for each of them and focusing on removability is very important, particularly for people that are treatment naive. I can say that one of the criticisms sometimes people have the silicone stents is that concern of its hydrophobic characteristic, but I feel that the covered stents have the same problem. That's why they're covered. And for malignant central airway obstruction, there are I can think of very few scenarios where we would do an partially covered or an uncovered stent. At least in our institution, we don't even stock those stents because they're never used. We're only using either silicone stents or fully covered stents. So when it comes to mucus plugging, technically both of them are going to have the same characteristics and the same probability of having the same issue.
The additional factor I would add in there also is with Y stenting. Remember that the silicone Ys are customizable on site. So my goal is always to put in as little plastic in the airway as possible. So my stents are as short in length and the limbs of the Y are short in length as needed, as opposed to, predetermined stent lengths. So customizability on site is another benefit of silicone stenting. This may be extended to say if you need to put a stent in the distal right main to the BI and you need a window for the right upper lobe, you can cut a hole in that. And similar scenarios where you can customize 3D printed stents, but which is not very relevant to malignant central airway obstructions. But I think these are additional factors which make silicone stenting preferable, but not from a complication perspective, because I think complications with either stent are equal when you're talking about while the stent is in. When it comes to time of removing the stent, silicone stents come out much easier.
Definitely. Now, talking about post-stent management, the guidelines recommend pulmonary hygiene measures to minimize stent complications, particularly mucus plugging. While a specific regimen isn't outlined, could you share some of the common practices among the authors regarding pulmonary hygiene, either the use of nebulizer, flutter valves, or mucolytics? When you guys, as authors, discuss this, did you have a preference of what to do?
So there are some really big name authors on this study, people who've, really done a lot of basic work with the stents. And as you mentioned earlier, it's a very, very diverse group. There are authors from 11 countries. Interestingly, none of the authors, including me, use anything other than saline nebulizations to keep the stent moist. Nobody uses expectorants, nobody uses mucolytics, nobody uses mechanical assist devices like flutter valves to help expectorate mucus and minimize stent-related complications. As you know, there is no data on any of this. All we know anecdotally and from maybe one small pilot study that you first authored called Salty Stent is that some sort of saline nebulization is needed, whether that's 3% or normal saline, whether it's BID or TID, I think needs to be individualized based on the type of stent, the material of the stent, the length of the stent, and also probably where you live. In drier places, I'm sure more frequent nebulization would be needed. So all authors use saline nebulization. Again, this is based on expert opinion. And really that's based on a lot of anecdotes of non-compliant patients having stent-related mucus plugging.
Definitely. And I can think that many of these cancer patients are already taking so many medications and wanting to add more and more and more without any evidence makes little sense. I think we should focus on things that the patient will adhere to and that will have a significant clinical impact.
Absolutely.
Now, the guidelines recommend surveillance bronchoscopies 4 to 6 weeks post stent insertion. Now, these recommendations in particular seem to generate the most debate among the experts. And we also seen differing opinions within our own faculty where I work regarding the necessity and optimal approach to surveillance. Can you explain the rationale behind the author's decision to recommend fixed interval surveillance bronchoscopy rather than a symptom-based approach?
There are a few studies looking at surveillance. Without going into the details, one of the studies does suggest that a lot of the patients who have stent-related complications are asymptomatic, and we tend to find a lot of stent-related complications when we do these surveillance bronchoscopies at 4 to 6 weeks, which in theory justifies doing something to prevent a complication from happening. And why is it important to prevent a complication from happening and acting in a reactionary way? That's because then you might have a mucus plug and a patient hypoxic, at the evening time. We know that emergent bronchoscopies are associated with higher number of complications based on the acquired registry data. So you want to avoid these inconvenient emergent procedures and act prophylactically. There is another study which looked at surveillance bronchoscopies at 2 to 3 months versus emergent bronchoscopies. But what is interesting is even in the emergent bronchoscopy group, about half of the emergent bronchoscopies needed to be performed within those 2 to 3 months. So based on that, what we can conclude is maybe 2 to 3 months is a little long. And based on the other study, maybe 4 to 6 weeks is appropriate. So using these two studies as a guide, we said maybe 4 to 6 weeks is an appropriate time to perform surveillance bronchoscopies. Of course, the strength of such a recommendation can never be high. It is still an area of debate. At Mount Sinai, we are conducting a prospective study. We have already started recruiting on which is randomized to surveillance versus no surveillance. What we can clearly say, though, is that some sort of follow-up is required. Right? Like you do not lose a patient who you put a stent in. You follow them in clinic. You can get follow-up CAT scans. Now we know that CAT scans may under-recognize endoluminal disease or sometimes overcall endoluminal disease where mucus may look like tumor. So CAT scans and clinic follow-up at the very minimum should be considered. However, surveillance bronchoscopies can also be considered and are recommended by this guideline, but this is yet to be borne out in a very good prospective study, which we hopefully get data on very soon.
I think that you answered my next question, which was going to be, could CAT scans be used as a less invasive alternative? And like you said, they could potentially be, but I think they should reserve for those patients that want to avoid a bronchoscopy as much as possible or do not have easily access to it?
So my practice is not a strict one. And even with CAT scans, these patients are invariably getting CAT scans from their oncologists. So I just try to arrange for a CAT scan that is convenient for the oncologist and for us on a time basis.
That makes absolutely sense. Many of our patients end up getting radiation as well. So they end up getting simulation, and one way or another, they end up getting a form of imaging. So we also follow that same practice of avoiding CAT scans unnecessarily if they're getting imaging one way or another. Now, the last question I had for you is, wanted to talk a little bit about respiratory failure in patients with malignant central airway obstruction. The guidelines recommend therapeutic bronchoscopy for patients in respiratory failure. In cases of severe respiratory failure where conventional ventilation or jet ventilation might be poorly tolerated, would you consider ECMO to facilitate a bronchoscopic intervention? And is there enough evidence to suggest that this combined approach can also aid in weaning patients from ECMO?
So there's two aspects to this, right? One is an aspect that you've also studied, is that patients who have severe central airway obstruction necessitating some sort of positive pressure ventilatory support. We have ample data now. Granted, it's not randomized. It's not feasible to randomize patients in such scenarios, where if you fix the central airway obstruction, patients get liberated from their positive pressure ventilation within 24 hours invariably. So this is known on multiple small studies, one that you did as well, and also from a large French registry which showed the same thing, 80% success rate in liberating patients from positive pressure ventilation once you fix the CAO with either debulking or putting a stent in. So in my book, treating critical central airway obstruction that is responsible for respiratory failure is an absolute must and must almost be treated with the same degree of urgency as, say, a pericardial tamponade. No matter how sick a patient, if they are suffering from severe dyspnea because of a massive pericardial effusion, you are going to drain that pericardial effusion to relieve their dyspnea. Similarly, central airway obstruction should be treated with the same urgency. And I say same urgency because if you leave a patient like this who's probably already weak on the ventilator for 3 to 5 days and then decide to intervene, you might be successful in relieving the central airway obstruction, but you might not be successful in extubating them. Now, specifically related to your question, what about ECMO support? I think this is an area of extreme controversy. ECMO should be used on a case-by-case basis. And I think that would largely be determined by the kind of critical obstruction you have and the proceduralist's level of comfort in relieving that kind of obstruction. For example, let's say somebody has a massive mediastinal mass and the proceduralist is not confident or comfortable or experienced in performing a rigid bronchoscopy to bypass the mass before deploying the stent. He or she may request for ECMO support at that time if resources are available. So I think this is a very scenario dependent thing. If you are comfortable, it should be something done very rarely, even in high volume centers. I have had to use it only once in my 7 years of doing interventional pulmonology. So I think it's very, very scenario dependent based on the specific patient in front of you, the type of airway obstruction, and the kind of skills and support you have available to you. So it's not something we can generally recommend or, comment on for generalization.
Yeah, it's so difficult to make research about this when the mortality of a cancer patient is so variable, right? And you have a patient presenting with one of the conditions that have the highest mortality, which is malignant central airway obstruction and respiratory failure. But if you add into that mix, what is the individual survival of each patient's cancer, then it makes that decision very difficult. And like you said, it's all about individualizing that decision. Now, Uddit, wrapping up, this is the last question. What else does the WAVIP has for us coming in the future?
We have already finished writing and forming consensus on our benign central airway obstruction paper. We have 20 authors on that, I think from 12 different countries again, and we've addressed 8 PICO questions. So hopefully we see that in print in the next few months.
Thank you so much, Uddit. This has been great. I think we're going to wrap up here, and thank you so much for joining us.
Thank you for having me.